Chitra, shall we start? Sir, shall we start, sir? Sir, shall we start, sir?
Yeah, you can.
So, good evening,
Yes, sir.
doctors. Yeah. So, good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for today's webinar. The topic for today's webinar is urinary tract infection and women's health. I welcome all the delegates who have logged in, and I request you to post your queries in the comment box so that we can have a short discussion at the end of the presentation. And it's time to introduce our eminent speaker for the day, Dr. Lalit Bora, sir. Sir is a senior consultant in obstetrics and gynecology, and sir is also the retired joint director of Health Service, Shivsagar, Assam. So I welcome you, sir. And sir, before going to session, we would like to play a short video on our Shield Connect web page, sir. So Chitra will play a short video on that, sir.
Here play koribo. এটা আনমিউট হৈছে নে?
So, sir, Shield Connect is a new initiative of our healthcare, sir. Find lot of informations on our web page. It has blogs from our experts, and it also have the informations about our webinars, and all our webinars are conducted through our Shield Connect web page only, sir. So you can see the details of all the webinars conducted by our Shield Connect, and you can see the list of upcoming webinars, and you can also see the details of our past webinars which is available in our website. And we also have a separate page for PCOS awareness program. So in this page, you can see various doctors, a short videos on PCOS delivered by various doctors in various regional languages. You can see a number of videos in our web page, and we also have a page for our leaders. So you can see the top leaders who are supporting our web page through their webinars and through their scientific contents. And I request the participants to go through the web page and make it useful. So thank you, sir. Thank you for giving the opportunity, and over to you, sir.
Okay. Okay. Yeah, good evening, everyone. Thanks for the nice introduction. I welcome all my senior and junior colleagues, ladies and gentlemen, to the today's webinar on urinary tract infection. It's my great pleasure to be a part of this webinar and share my experiences with the esteemed doctors. Urinary tract infection is a very
Sir,
common
sir, you
infection.
can start sharing your screen, sir. Sorry, sir. Sorry for
Okay,
interrupting, sir.
okay, yeah.
Yes, sir.
I
Thank you,
think
sir.
it's visible, no?
Yes, sir.
Yeah, urinary tract infection is a very common infection affecting more than 10 millions of people in India in a year. It's an infection in any part of the urinary system, the kidneys, the bladder, or the urethra. It's more common in women than men. They usually occur in bladder and urethra, but serious infection involve the kidneys. Then what is a urinary tract infection? If you go through the slide, a urinary tract infection is an infection occurs when bacteria invade the urinary tract. It is the second most common infection in the body. Women are especially prone to urinary tract infection for an unknown reason. One in five women develop a urinary tract infection during their lifetime. Urinary tract infections are not as common in men but can be more serious when they occur. Women are especially prone to UTIs for an unknown reason, though many contributing factors are responsible for UTIs in women. Next, next, please. Next. Yeah. So urinary tract infection, if you see, go through the incidence, adult women 6 to 10% per year, pregnancy 4 to 10%, single catheterization 1 to 3% for normal patient, 10 to 15% for the debilitated patient. Female male ratio overall 10 to 1. Male incidence below the age of 1 and above the age of 50, it is more serious conditions. As you know, most of the women need catheterization during vaginal delivery or cesarean section or any gynecological or general surgeries. So epidemiological conditions, if you see, asymptomatic bacteria that develops in 13 to 10 to 13% of the patient, acute cystitis 1 to 4%, acute pyelonephritis 0.5 to 2%. Incidence of bacteria in pregnant women slightly higher than non-pregnant women, but prognosis to pyelonephritis is significantly higher, that is 40%. The rate of recurrence has not been calculated by any major studies. Women are especially prone to UTIs for an unknown reason, though many contributing factors are responsible for UTIs in women. That we have already said. Next. Certain factors are thought to be responsible as predisposing factors for urinary tract infection, like obstruction, calculi tumor, benign prostate enlargement, extrinsic or intrinsic factors which pressurize the urinary tract, either in the urethra, in the bladder, or in the kidneys. There is vesicular ureteral reflux, There might be complete bladder emptying, which may be voluntary or neurogenic, especially following surgery, intrapartum and postpartum period. Diabetes, sickle cell anemia, immune compromised states, bladder instrumentation, foreign bodies in the urinary tract, congenital structural abnormalities. It plays an important role mainly in the pediatric cases. Sexual activity and pregnancy are the most common predisposing factors for urinary tract infection. Next. So, how to diagnose the urinary tract infection? From sign and symptoms, physical examination, laboratory test, out of which dipstick is very useful, and its criteria to diagnose UTI are dipstick, that is chemistry 9, leukocyte esterase, fairly accurate if 2 plus, gram stain if 1 bacteria per high power fill indicates urinary tract infection. Microscopic examination of urine for the squamous cells is important. Urine culture and sensitivity, which is most important for the diagnosis of urinary tract infection. So it is a slide for mouse over or touch below for results. There are various color indications as you have seen in the slide or changes of color for nitrate, pH, protein, blood, specific gravity, ketone bodies, glucose and bilirubin. And by seeing the colors in the dipstick, we can diagnose the urinary tract infection as you have seen in this slide. Okay. Next. In microbiology, what are the organisms that are responsible for urinary tract infection? If you go through, then Escherichia coli, that is mostly known as the E. coli, 63 to 85% of the cases they are responsible for urinary tract infection. Klebsiella pneumoniae, 8%. Coagulase negative Staphylococcus, up to 15% of cases it is responsible. Staphylococcus aureus, up to 8%. Then group B streptococci, GBS, they are responsible for 2 to 7% of the cases. Next. Then regarding sign and symptoms, depending upon the site of infection and age, urinary tract infection symptoms may differ sometimes. In adults, there might be dysuria, frequency, urgency, nocturia, suprapubic pain, back pain, hematuria, cloudy urine, and aneuryosis. These are the main symptoms for the adults. Next. For symptoms, urinary tract infection may cause pelvic pain, urge to pass urine, painful micturition. There might be blood stained urine. There may be backache, nausea, vomiting, fever, and chill. Strong persistent urge to urinate, burning sensation when urination occurs, passing frequent small amount of urine. Urine may appear cloudy and urine may appear red, bright, pink or chocolate colored depending upon the presence of blood in urine. There might be strong smell of urine and pelvic pain in the mostly in women. And if you go to the sign and symptoms of babies, then baby may be lethargy, poor feeding, fever or hypothermia. There might be vomiting. They might suffer for diarrhea and strong smelling of urine may be there. Types of urinary tract infection. Each type of urinary tract infection may result in more specific signs of symptoms depending on which part of one's urinary tract is being involved. In case of acute pyelonephritis, when the kidneys are involved, signs and symptoms are upper back and pain in the flanks, fever, there is seal and rigor, nausea, vomiting. Next one. The clinical presentation may be the most common form of recurrent UTIs is recurrent persistent asymptomatic bacteria. However, it may also present as acute cystitis or acute pyelonephritis after an untreated primary asymptomatic bacteria. If there is infection in the bladder, which we usually call the cystitis, pelvic pressure or heaviness in the lower abdomen, there might be discomfort, frequency, painful micturition, there may be blood in the urine. And when there is infection of the urethra, which we call urethritis, burning with urination or urethral discharge may be there. Now, why does urinary tract infection occur? When organisms like bacteria enter the urinary tract through urethra and begin to multiply in the bladder, although the urinary system is so designed to keep the microorganisms invaders, this defense sometimes fail. When that happens, organisms may take hold and grow into the full-blown urinary tract infection. But urinary tract infection may also be caused by hematogenic route too, which is very unusual, of course. Cystitis, infection of the bladder, usually caused by Escherichia coli, sexual intercourse in newly married couple, known as that most of the people they used to call as honeymoon cystitis, but one doesn't have to be sexually active to develop cystitis. In case of urethritis, infection of urethra, this type of infection is usually develops when gas GI bacteria they spread from anus to urethra. As female urethra is close to vagina and women are at risk due to their anatomy, short urethra, and short distance from urethra to anus, sexually transmitted diseases like herpes, gonorrhea, chlamydia, and mycoplasma can cause urethritis. So asymptomatic bacteria, if you go to the definition, according to recommendation developed by IDSA, that is Infectious Disease Society of America, significant bacteria in asymptomatic women is defined as bacterial monoculture in the quantity of more than 10 to the power 5 colony forming units, CFU, per ml into consecutive midstream clean cats urine specimens or more than 10 to the power 2 colony forming units per ml in urine collected from single urinary bladder catheterization. One thing we have to know, the babies are also very much prone to develop urinary tract infection and their symptoms are very much different from adults. Babies become lethargic, don't show any interest in food and becomes very difficult for parents to feed them. There may be fever, hypothermia, vomiting, and diarrhea too. Of course, one important sign is strong smelling urine. Asymptomatic bacteria screening, American Academy of Pediatrics and American College of Obstetrician and Gynecologists in 2012, as well as United States Preventive Services Task Force 2008 recommended screening of bacteria in the first prenatal visit or at 12 weeks, whichever is earlier. Next. Asymptomatic bacteria, the significance of it, if asymptomatic bacteria is not treated properly, approximately 40% of the infected women will develop symptomatic infection during pregnancy, which is a very serious condition for the pregnant woman. Next. Now come the acute cystitis. Acute cystitis affects approximately 1% of all pregnant women. Acute cystitis is in pregnancy almost always result from ascending infection in long-standing asymptomatic bacteria. So we must give stress for when we come to our clinic, at least in the antenatal clinic, the women should be asked for during pregnancy or prior to pregnancy for examination of urine because most of the women they might suffer from asymptomatic bacteria which may later develop to cystitis or pyelonephritis. As we have already told certain symptoms of acute cystitis, I just repeat dysuria, frequency, urgency, suprapubic pain, hematuria, lower urinary tract symptoms with pyuria accompanied by sterile urine culture may be from urethritis caused by chlamydia trachomatis. One of the very important part of the urinary tract infection is acute pyelonephritis. It is the most common serious medical complications of pregnancy. Pyelonephritis was the leading cause of septic shock during pregnancy. Pyelonephritis unilateral in most of the cases, but half of the cases, and it is bilateral in a fourth of cases. Here, I would like to share my experience with all the doctors. Recently, we have come across a woman in her 34 weeks of pregnancy. She came with uh, high fever, there was malaise, and she was in shock. And at the very onset, we just couldn't think of urinary tract infection and what is the cause of shock. Then we have admitted her in ICU, and later on, when all the investigations were carried out, she came out to be a case of acute pyelonephritis. And later on, when she was treated, in when she attained 38 weeks of pregnancy, we delivered her by cesarean section. Sign and symptoms. Abrupt onset with fever, shaking chills, aching pain in one or both lumbar regions, anorexia. There may be nausea and vomiting. Tenderness could be elicited at costovertebral angles, or we call them the renal angles. Microorganisms which are responsible to cause acute pyelonephritis. In most of the cases, Escherichia coli is the culprit. 70 to 80% of cases we find Escherichia coli. Klebsiella pneumoniae, 3 to 5% of cases. Enterobacter or Proteus, 3 to 5% of cases. Gram-positive organisms, including group B, Streptococcus and Staphylococcus aureus in 10% of the cases. Now, to diagnose acute pyelonephritis, though renal biopsy is the gold standard for the diagnosis of pyelonephritis, but it is impractical in clinical practice. In our clinical practice, definitely we will have to depend on the sign and symptoms full blood count, inflammatory markers, renal function test, blood culture, urine culture, and sensitivity test. These are the most important tools through which we can diagnose the acute pyelonephritis. And what might be the medical complications of when a woman develop acute pyelonephritis? Endotoxin induced alveolar injury manifest in 10% of women can lead to frank pulmonary edema. It may be severe enough to cause ARDS. Endotoxin also causes hemolysis and anemia. Bacteremia is demonstrated in 15 to 20% of cases, and transient renal dysfunction, it is 2%. Acute pyelonephritis obstetrics complication, preterm labor before the 37 weeks of pregnancy. Preeclampsia may be there at any time after 20 weeks of pregnancy. Chorioamnionitis and postpartum endometritis. These are the main complications of acute pyelonephritis. Acute pyelonephritis fetal complications. The baby may be underweight, low birth weight is there if the baby weighs 2.5 kg and below that. Prematurity before 37 weeks of gestation, if the woman she goes into labor, developmental delay or mental retardation, and perinatal mortality and morbidity. Differential diagnosis, if you consider of acute pyelonephritis, then we can go through all these differential diagnosis like chorioamnionitis, appendicitis, placental abruption or abruptio placentae, infracted leiomyoma if somebody is having leiomyoma during her pregnancy, or it might be from the prenatal period also. If you come for the management, how to manage the urinary tract infection, then we can see the single dose treatment of amoxicillin 3 gram, ampicillin 2 gram, cephalosporin 2 gram, nitrofurantoin 200 milligram, dimetroprim sulfamethoxazole 320, and 1600 milligram. This is the 3 days. That was the single dose treatment for the asymptomatic bacteria. A 3-day course can also be advocated. These are amoxicillin 500 milligram 3 times daily, ampicillin 250 milligram 4 times daily, cephalosporin 250 milligram 4 times daily, ciprofloxacin 250 milligram twice daily, levofloxacin 250 or 500 milligram daily, nitrofurantoin 50 to 100 milligram 4 times daily or 100 milligram twice daily. Trimethoprim sulfamethoxazole combination 160 and 800 milligram 2 times daily. Along with this single dose treatment and 3-day course, the other treatment is with nitrofurantoin 100 milligram 4 times per day for 10 days, or we can go for 100 milligram of nitrofurantoin twice daily for 5 to 7 days, or nitrofurantoin 100 milligram at bedtime for 10 days. Treatment failures, nitrofurantoin 100 milligram 4 times daily for 21 days, we can advocate. Now, how to follow up the asymptomatic bacteria, the patient who doesn't develop any sign and symptoms, but most of the cases they used to come to the clinician or to the obstetrician with the history of frequency of micturition. And if we ask the patient, especially me, when I think that somebody is having the asymptomatic bacteria, then I used to inquire how many times he used to go for urination during nighttime. Most of the women, they used to go for urination for 1 to 2 times only. But when there is asymptomatic bacteria, then the patient used to passes 4 to 6 times after they go to their bed, and during the daytime they used to have frequency of menstruation. All these things they used to say only if we inquire about their urination during daytime and nighttime. Follow-up cultures should be obtained in 1 to 2 weeks after treatment and then repeated once a month. If we go for the management of persistent recurrent bacteria, nitrofurantoid we used to prescribe most of the time 50 to 100 milligram at bedtime until the end of the pregnancy. A postpartum urologic evaluation may be necessary in patients with recurrent infections. In recurrent infections, more likely to have structural abnormalities of the renal system. Now, acute cystitis in pregnancy developed due to ascending infection in prolonged asymptomatic bacteria, and acute cystitis affect approximately 1% of all pregnant women. Increasing oral fluid intake is frequently advocated as a first-line treatment for pregnant women with features of symptomatic urinary infection. I prefer nitrofurantoin twice a day, 100 milligram in each time for 7 days. Urine alkalizing agents are used. And third thing is cranberry juice also act as urine alkalizer and is used to treat urinary infection and inhibit the symptoms. Acute pyelonephritis, if you see the management, hospitalize the patient, obtain urine, especially if you can get the midstream urine that is better, and blood cultures. And if you cannot obtain the midstream urine, then catheterization is also advocated. Evaluate hemogram, serum creatinine, and electrolytes. Monitor vital signs frequently, including urinary output. Consider indwelling catheter in that case. Established urine output should be 50 ml or more than that per hour with intravenous crystalloid solution. Acute pyelonephritis, for the management, non-steroidal anti-inflammatory drugs can be added for symptomatic relief. Thromboprophylaxis should be used if the woman has reduced mobility or a period of bed rest. Compression stockings, which is very good for these cases, and low molecular weight heparin is advocated. Tocolytic drugs is frequently necessary to prevent preterm labor. Antenatal steroids for fetal lung maturity should be considered because preterm labor is very common in acute pyelonephritis. Antimicrobial of choice are mild or moderate acute pyelonephritis, ceftriaxone 1 gram every 24 hours, cefepime 1 gram every 24 hours, amoxicillin with clavulanic acid 1.2 gram every 12 hours, azithromycin we can give 1 gram every 8 to 12 hours. In severe acute pyelonephritis or in cases where there is immunosuppression or urinary stasis, ticarcillin with clavulanic acid 3.1 gram every 6 hourly, piperacillin with tazobactam 3.375 gram every 6 hourly, meroperidone 0.5 gram every 8 hourly, ertapenem 1 gram every 24 hours, doripenem 1 gram every 8 hours. Now, FDA, that is United States Food and Drug Administration categories of medications in pregnancy. FDA risk category is there. So, amoxicillin, cephalosporins, piperacillin, tazobactam, diptomycin, azithromycin, erythromycin, morphenam, clindamycin, nitrofurantoin, vancomycin, and metronidazole intravenous and vancomycin intravenous. These are all B category drugs, and trimethoprim is C category drugs. So others like trimethoprim, ciprofloxacillin, levofloxacillin, imipenem, linezolid, clarithromycin, spiramycin, and gentamicin, all these are FDA C category drugs. Amikacin, tobramycin, netimycin, and tetracycline, they are D category drugs. So during pregnancy, definitely we will have to consider both the mother and the baby and whether these antibiotic they affect the fetus in utero. We'll have to consider that one too. Newer antibiotics has come up. Fosfomycin, of course, it is also known as monurol, is a new antibiotic that is taken as a single dose. It's a broad spectrum antibiotic produced by certain streptomycin species and has bactericidal action. Administered as a single dose of 3 grams sachet, category B drug, better compliance, and it is cost effective as it is written in the slide. It is 280 rupees per sachet. Now, we are treating acute pyelonephritis as we can, but what if acute pyelonephritis does not respond to treatment? Persistent acute pyelonephritis infection. So hydration is very important for these patients. Intravenous hydration and antimicrobial therapy followed by stepwise defervescence of approximately 1 degree Fahrenheit per day with persistent spiking fever or lack of clinical improvement by 48 hours to 72 hours, urinary tract obstruction, other complications along with it, it is considered to be persistent infection. Causes of persistent infection, we can add urinary tract obstruction, abnormal urethral or pilocalicial dilatation, intrarenal or perinephric sepsis, nephrolithiasis. These are the common causes of persistent infection. Now, if you go through the management of persistent infection, ultrasonography is very important. It plays a great role for diagnosis and for the management. Ultrasonography of kidney, ureter, and bladder, or one-shot intravenous pyelogram or MRI to detect the cause of persistent infection. Obstruction relief is important. We can do cystoscopic placement of a double J ureteral stent, percutaneous nephrostomy, or surgical removal of stones if there is. What is the cause of recurrence in low count bacteria or even negative cultures? Answers lies in intracellular bacterial colonies forming, that is biofilm. And in this biofilm, we see uropathogenic E. coli, that is U- UPEC, E. coli CFT 073, UTI 89, and 536 invades urethral cells lining which forms intracellular bacterial communities, that is IBCS or biofilm. This infection remains undetected in normal urine cultures and causes recurrence. So in most of the cases, during treatment or after treatment, if you go for the urinary routine examination or culture and sensitivity test, in most of the cases, the urine cultures become sterile. These culture negative infections present an unexplained dysuria and urgency and are termed as interstitial cystitis or bladder pain syndrome. So this is a slide showing the culture positive and culture negative. There is early RBC, there is the reservoir. From the reservoir, it goes to the it goes for the recurrence, or it might be from the slough. There is sloughing, there is late IVC, flushing, filamentation, binding, and invasion. And on the left hand side, this is the these are culture positive, and on the right hand side, it is culture negative. Prevention of recurrent infection, continued antibiotic prophylaxis till the end of the pregnancy in the form of nitrofurantoin 50 to 100 milligram that is given once a daily at bedtime. Intake of 150 to 750 ml of cranberry juice or concentrated equivalent is effective in preventing recurrent UTIs. Maintaining local hygiene. Yes, here I would like to suggest something. Local hygiene, especially for the babies, newborn, and the babies who cannot take care of themselves. Mothers should be treated, means mothers should be, uh, they should be advocate how to do the proper hygiene. And when the napkins are used or nappies are used for the cleaning of the private parts, that should be from the anterior to the posterior side and not the reverse one. Because if they do the reverse one, that is from the anal portion to the vaginal part or upward, there will be chances of infection from the anal part. So I am not going to tell only for the mothers, but because nowadays both the parents are equally responsible. Most of the ladies, they are working one, so both the parents, they should take the responsibility for the maintenance of local hygiene of their babies. Drinking at least 3 to 4 liters of water, that is very important. During the antenatal clinic, whenever the patient comes to me or patient comes to almost all the gynecologists, uh, especially me, I used to recommend at least 12 to 15 glasses of water or fluid one should take during the period. Women who are sexually active can be advised to postcoital voiding. That is also very much important. And women, those are those who are very sexually active or who do have more than one partner, they should be more aware of all those things. Conventional treatment, uh, we can give alkalizer when there is burning menstruation. If there is pain or dysuria during urination, flavoxid is important. And nowadays, most of the companies they are coming up, or they used to say, they were to prevent the recurrence. Cranberry is very important. So, uh, pain, burning, micturition, and recurrence to avoid all these things, arsenic acid, potassium magnesium citrate, and cranberry, and mannose. All these things are important. And as the company has claimed that UTI flask is best one, arsenic acid it contains for the pain management, powerful anti-inflammatory and analgesics, anti-inflammatory effect comparable to indomethacin, a powerful NSAID, rapid relief from pain one used to get. For the burning micturition, potassium magnesium citrate, it is there in the ATI flask, normalizes the pH of acidified urine in the infected urinary tract infection. Then cranberry extract, active ingredients of it exert anti-adhesion property. Lastly, mannose, D-mannose exerts anti-adherent property too. So burning micturition, pain and recurrence of UTI. UTI flask is a good one. I have used it many a times to so many pregnant women, and even for the ladies, though they are not pregnant, they are coming with uh, all the signs and symptoms of urinary tract infection. Definitely, I used to prescribe it by flask of seal, and it gives good result. In and the dose is in acute painful UTI, one sachet OD for 14 days, and in recurrent UTI, that should be continued for 28 days. So before rollout, the take-home message from my side for the viewers, that is pre and post conceivement examination on first visit or before 12 weeks of gestation, urine for asymptomatic bacteria should be emphasized. Unnecessary catheterization should be avoided. Obstructive lesions causing urinary retention and UTI, when detected, should be treated early as soon as possible. Then persons of all age group from pediatric to geriatric and especially the pregnant women should be taken care of early and should not be neglected. Last but not the least, awareness should be made amongst people of our society regarding taking of plenty of fluid, water intake, at least 15 glasses or 12 to 15 glasses of pure drinking water daily if there is no medical contraindications for the particular person, because there are so many medical conditions when the doctors they do not advocate to take fluid or water, and it is only recommended by the clinician concerned. And I thank all my colleagues for their valuable time and active participation. I am really grateful to the organizers and office bearers of SEAL Company for trusting me and giving me the opportunity to deliver the speech on such an important topic in New FSR 2. I would like to be associated with the company, with the all person concerned in such academic activity. Thanking you all once again.
Thank you, sir. Thank you very much for that wonderful presentation, sir. Hope our viewers also would have been gained good knowledge on our UTI infection, sir. Sir, let me wait for 1 or 2 minutes for the
Okay.
participants to post their queries, sir. If there is any queries, they can share with us, sir. And sir, I request you to share How will you manage UTI in first trimester of pregnancy, sir? What will be
Yeah,
the treatment and management?
yeah. For the first trimester of pregnancy, or if the patient comes for counseling in the pre-pregnant state, definitely uh, I'll go for the uh, asymptomatic bacteria. I will do the routine examination of urine for her along with other tests and the urine for culture and sensitivity test. And if she comes with pregnancy, and one more thing, if she comes the pre-pregnant state, definitely I will be treating the woman if she is having asymptomatic bacteria. And if she comes in the first trimester of pregnancy, that is before 12 weeks of pregnancy, definitely along with other counseling for her, more counseling should be done for the asymptomatic bacteria, one thing. Second thing, uh, she should be treated mainly on nitrofurantoin, which is very safe during this period, or we can go for a routine examination of urine along with the culture and sensitivity test if she is having some sign and symptoms of urinary tract infection in the first trimester of pregnancy.
Thank you, sir. Sir, and what about the use of probiotics in treating UTI, sir? Whether it will be when we are prescribing probiotics, whether it will reduce the recurrence of UTI, sir?
Yeah, nowadays most of the companies they are coming out with the pre and probiotics, and they used to claim that even in the first trimester of pregnancy also they can use pre and postbiotic uh, for the vaginitis as well as for the treatment of urinary tract infection too.
Good, sir.
Yes, any more question?
Sir, I cannot find any other questions in the chat box, sir.
Okay,
Sir, if you allow us, then we can end the webinar for today, sir.
okay, okay. Thanks everybody.
Yes, sir. Thank you. Thank you very much
Okay,
for
for
being
the
with us
nice
today, sir.
evening that they have participated. And really, I welcome once again all in the my near future. If there is any topic is there for me from the SIL side, I am always there to help you.
Sure, sir. Sure, sir.
Okay,
We
okay,
always looking forward for you, sir.
okay. Thanks everybody and good night.
Thank you, sir.
Okay.